malnutrition resources. As Meredith said when she introduced me, I'm a social worker by trade. I'm not content to just ask the question. I want to do something about it. And so that's what we did. Next slide, please. Yeah. So as part of the charitable pharmacy, in order to get your medications from us, you must be qualified. All new patients qualify the first time they come and once a year. So we integrated this dual purpose screening tool into the qualification interviews that were performed by myself. And they were asked these questions, some other information, demographic information, gross income, what nutrition resources they were already using. Do you already use food pantries or SNAP, et cetera? And then those who were screened positive were also offered referrals to these other resources. All of the results were recorded in our electronic health record and encrypted in a spreadsheet that was eventually de-identified and shared with the whole research team. So this was performed at the very beginning of 2020. I'm sure you all might know there was this thing that happened around March of 2020 that kind of threw a wrench in just about everything. However, we did from the very beginning of January until the wrench was thrown in everything, we managed to screen 221 patients for nutrition risk. And of those 221 patients, 63% were positive for food insecurity, malnutrition risk, or both. As you can see in the slides here, 84 or 38% were positive for just food insecurity, 6% for just malnutrition risk, and 19% for both. So this was definitely something that was shocking to us, but not necessarily surprising. We understand that our patients are, healthcare insecure. It makes sense that they might have these other needs too. As I said, one of our goals with this was to characterize our population. Predominantly, we found, as I said, our average age is 60. So we found most of the patients that we screened were in 50 to 59 or over 60. Majority patients were Black, 53%, 36% were white. And income was pretty variable. As you might see, there are some that are over 200%. That is because this is gross income before taxes that most social service agencies use. So that's how we measured it. For charitable pharmacy, it has to be after taxes that you're under this limit. And 45% were uninsured. The majority, however, 38% were on Medicare, and that includes those who age into Medicare and those who get Medicare through qualifying for disability. Next slide, please. So when we looked and kind of broke down the nutrition risk into these different categories, we found that majority of Black patients that we screened were at nutrition risk. As well, as I mentioned in the previous one, that 40 to 49 years and 50 to 59 years were the ones that were at highest risk of having some kind of nutrition risk. 70% of the patients who were 50 to 59 screened positive. And the 60 plus, which this tool was developed for, was actually the smallest percentage of nutrition risk. Next slide, please. As well, we looked at income. We had, I would say 101 to 150%. 73% were at nutrition risk, which is, I would say, under 2020, that was probably about $1,000 to $1,500 a month when we talk about percent of the federal poverty line, and that's gross. So that's before they get their taxes taken out. That doesn't even constitute what they actually bring home. And we found the highest rates, of nutrition risk in the uninsured and Medicare populations, which is makes sense considering those are the largest percentage of populations we serve. When we look at rank order, rank order nutrition risk, patients most likely to be food insecure are Black, uninsured or on Medicare, 60 or above, and 30% or gross income 0 to 50% of the federal poverty line. Very similar for malnutrition risk and both food insecurity and malnutrition risk combined. And that gross income being 0 to 50% of the federal poverty line, we have a lot of patients who are unemployed for various reasons, or come to us because they suddenly found themselves without insurance. Next slide, please. So the other aim of this project was really to, not just identify where, who these patients were that were at this nutrition risk, but do something about it. So this involved asking them about current use of resources and then referring them to additional resources. And this bottom with the type of resource, they can report many. There's a lot of people were using more than one. Food pantries were by far the most common and the most commonly requested. A couple interesting things that we found. So, for one, we had some people who told us that, they rely on their friends and family to help them get money for food. We did not refer them back to that. We tried to see if we could set them up with other resources. And one resource that I found, this ended up being anecdotal, but I heard it several times, was that, as you can see, SNAP or food stamps was typically that is a government benefit meant to reduce food insecurity. We had about 23 people report having used SNAP, but when I offered that as a resource, as a referral, I had a lot of people tell me they were not interested because they had SNAP before and received between $15 and $20 a month, and they did not feel it was worthwhile to apply, to go through all the steps to apply for SNAP to get that much money. These were single adults who worked, no children. So it's a one-person household getting the bare minimum, and it just was not worth the effort of trying to apply. And this, as especially as a social worker, this was the table that really kind of hit home the most for me. As a social worker, my job is to identify these needs for patients and help connect them to resources that can meet these needs. But and so, when we ask them, what are you usually using right now? And do you need additional resources? Down at the very bottom, last row, were patients who were using resources already, who were already going to food pantries, already using SNAP, already getting some kind of assistance, using some kind of resources to get food, and asked or accepted additional resources. 98% of them were at nutrition risk, meaning that whatever they were already using to address their food insecurity or address their nutrition risk was not working. They needed more help. And this really, was big for me because, that's the idea. They're doing what they're supposed to do, and they're already utilizing the tools they have, but the tools are not addressing the problem enough, that they are still testing, they're still screening positive for nutrition risk. We also found that, 91% of those who were not using any resources and required resources were also at nutrition risk. And, there were, just in general, as we found, most of patients were at nutrition risk. A lot of them were using some kind of resource, either before or after, and they were still screening positive. Next slide. And another thing that was very interesting to us, so for the questions regarding malnutrition risk, the two questions that we ask are, has there been any time lately that you have lost any weight without trying to? And has there been any time that you haven't eaten much because you just don't have an appetite? And when we ask about unintentional weight loss, there are different ranges of weight loss, and each range and each question have a score attached to it. If it's a score of 2 or higher, you're considered at malnutrition risk. What was interesting to us is that we had several patients who reported some level of unintentional weight loss, but it was only when it was 14 pounds or above did they screen positive for malnutrition risk. As you can kind of see here on the left, there were several who were considered at no nutrition risk or just screen positive for food insecurity that did report some kind of unintentional weight loss. It just wasn't enough to trigger this positive screen. And what was interesting to us is that we had several patients who reported some level of unintentional weight loss, but it was only when it was 14 pounds or above did they screen positive for malnutrition risk. And And we just thought that was very interesting and something to watch, because, it could be 13 pounds a day, but how, if it's some kind of health condition that it is causing them unintentional weight loss or causing malnutrition, that could be going up, but, we don't have that screening or triggering some kind of additional response. Next slide, please. And I went through a couple of these, but some of the highlights, as we found in our results of the, just 2/3 of our patients screening positive for some kind of nutrition risk, is that those who are most likely to be at nutrition risk responded often true to questions regarding food insecurity. They were considered food insecure if they were asked in the last year, have you run out of food, or have you worried to run out of food before you get more? And if you said sometimes or often to either one, you were considered food insecure. So the ones who are most likely to be at nutrition risk responded, that is an often true thing, that it happens a lot, and report 14 or more pounds of unintentional weight loss. When we talk about where, these resources and referrals that we make, one thing that we found was for the 56 patients that had malnutrition risk, that most of them were uninsured or on Medicare, meaning that access to a dietitian to get this addressed and diagnosed was very, very difficult. Medicare is very specific about who qualifies to see a dietitian that is paid for by Medicare. And obviously, if you have no insurance, then it's difficult to see any healthcare provider. As I mentioned, we found anecdotal, there was a lot of single adults with no children who reported receiving very, very little in SNAP benefits, that they did not feel it was worthwhile, worth the effort to apply for. And overall, the data suggests that those who are healthcare insecure, who are uncertain if they can access healthcare when they need to or can afford to, are also likely to be at nutrition risk. And kind of looking forward to what we've done since this project in early 2020 and what we are doing kind of here moving forward. One thing that we have planned for this data is to look at malnutrition risk specifically in the elderly versus non-elderly populations. We are currently working on a partnership to open up some access to a dietitian so that we can validate the nutrition tool by getting patients who screen positive for malnutrition risk a nutrition assessment by a registered dietitian. We'd like to collect survey feedback from patients about access or barriers to getting, using the nutrition referrals. This was built into our original plan, but COVID had other plans. And then this is something that we used a lot at the beginning of 2020, but we have been using since. We integrated it into a cardiovascular health program that the pharmacy offers to its patients. And I'm really looking forward to seeing some kind of longer term data that, if giving them the resource referrals, are they still screening positive over time? Is this changing? And, is what we're providing helpful or not? And finally, the most exciting part is that this tool and its use at the pharmacy fits into a wider kind of theme and direction that we are headed in, which is food as medicine and medicine as medicine. We just opened a second location of the charitable pharmacy here in Columbus, in a very underserved neighborhood. And it is in the same building as a fresh produce market. Patients who are referred to this market or to markets similar here in Franklin County from healthcare partners like myself, or the charitable pharmacy, can access fresh produce for free once a week. It's a program called the Mid-Ohio Pharmacy with an F, through Mid-Ohio Food Bank, Mid-Ohio Food Collective, sorry, they changed their name, and that we are really working on helping people get this produce, as well as giving them resources of how to use it, different recipes to improve their health overall. I think that's where the slides end. So I see several questions, so let me take a look real quick.
Yeah, there are some great questions in the box. The one, and I'm also curious about this, the citation for where was this published and when, so that folks can read the study for themselves.
Yes, I should have included that. I didn't think to. It was published in the Journal of Healthcare for the Poor and Underserved in August of 21. So that was their, I believe that was their like third quarter. I don't remember how they do volumes, but yeah, it's Collier et al. 2021 in Journal of Healthcare for the Poor and Underserved.
Okay. And I
can
link
drop
to
it. I'll drop it in the chat.
Yeah, thank you. And I was going to say I can link to it on our website with the slides and recording as well. So
that'd be great. Yeah. So a couple of the questions. So I see one is, do you think patients had some kind of embarrassment answering questions in the food insecurity screening tool? What do you think are some better ways to use this tool and get more accurate responses? Personally, and I will say I did every screening myself. I did not, I don't think I had any patients who really felt embarrassed or didn't tell me. I mean, there were certainly some who said, like, I would say, you know, I have a couple extra questions. Can I ask you? And they did not care to be asked, which was fine. But I didn't have anyone who really was embarrassed that I can recall. And I think a big part of anything like that, where you're asking these questions to vulnerable people about potentially sensitive subjects, is to just make sure that you're creating, you know, building trust and creating an atmosphere where they feel comfortable talking about that. And also kind of avoid asking the question to ask the question. You know, that's what I kept saying, like, I'm a social worker, I want to do something about it. I don't want to just screen you and then you say, yes, I'm having a really hard time getting food, and then just go from there. Like, okay, well, that's good. I'm going to mark that down and keep going. Like, we want to make sure that when we ask those questions, we have a reason to, and that it's because we want to do something about it. Another question, and I'll also, I'll put the journal article, and I'll also put the link to the tool itself in the chat when I'm done. So another question is, do you have any idea why the two mid-age groups had greater proportions of risk compared to the older population? I have theories. I will say I think part of it was household size and support. I think overall it's always income. That, you know, we had a lot of patients who are, you know, overall in the pharmacy. A lot of them are on Social Security disability. So they're on a fixed income at younger ages than most people assume when you have a fixed income, is that you're older, you're retired. Like, these are people in their 40s and 50s. And I would say that's probably the biggest risk. We did not look specifically at health conditions. This was a general one. The way we use it now is for specifically hypertension. But yeah, I think it was mostly had to do with their income and some of their support. And I feel like I saw.
Yeah, there question in the chat box as well.
Yes. Have you given any thoughts to ways to scale up this program and more sites outside of a charitable pharmacy setting? And do you foresee a way to implement a program without a licensed social worker? Could pharmacy techs or other staff be trained to conduct this screening? So yes, so the goal of this tool overall is to be used in community settings. So we're a community pharmacy setting. Jay could speak more to this if you were here, but the goal, you know, his experience with malnutrition in the hospital setting is that, you know, that it is not always well translated into the community setting, that, you know, they do nutrition assessments, they talk about it when you're in the hospital, but it does not necessarily make it to the primary care doctor, to the pharmacy. There's no translation there. Transition of care doesn't happen very often. So this was, you know, part of the goal of this tool specifically was to increase screening in different community settings. So we haven't had a plan our project specifically with the charitable pharmacy, but the tool is definitely meant for a broader scale. And as far as how do we do this without a social worker, the other people can definitely be trained to conduct and these screenings. So when this happened, it was just me. I now have a team of 5 that includes another social worker, a community health worker, and a pharmacy technician, all of whom are trained to ask these questions and are basically introduced, make sure, the biggest thing I think would be to make sure that they have an understanding of what's available in the area and just, they have some kind of background or can be, introduced to the background of food insecurity, malnutrition risk, and what do we do about it? And then another question of how will malnutrition risk in elderly be assessed in the future? Is there a specific tool that you plan on using? So we plan to, this tool was developed specifically for older adults, so we would not necessarily be using a different tool. We just have an interest in looking at just this data in an elderly versus non-elderly population. This one we looked, very broadly at the population overall. We have some interest in doing this more comparative elderly versus non-elderly. And were there resources beyond SNAP and dietitian referrals that we were able to utilize? Yes. So I had a lot of lists of food pantries. I'm very lucky. I live in Columbus, Ohio, which there is a lot of resources in Columbus, Ohio. So I made sure that I had very up-to-date information on publicly available food pantries, made sure we have a private food line that patients call to be scheduled for private food pantries. I met with different organizations. We created the partnership with Mid-Ohio Food Collective. And I will say there were they were specific to our area. So if you're, a lot of that kind of things are things you would develop lists of resources for wherever you are. Yeah, we focused on food pantries specifically, but there were a lot of different ones. And, as, malnutrition professionals and different backgrounds, you could probably come up with something I didn't think about, but just whatever might meet the need that the patient is expressing. And one thing that I should say is very interesting about malnutrition risk specifically is that referring them to talk to their doctor or pharmacist was fairly common, because I would have some people who would say, yeah, I don't eat, I don't have an appetite, or I've lost a lot of weight unintentionally. And I kind of dig into it a little, like, what, do you know why? Some people would say mental health. Some people would say, my medicine makes me sick. I'm like, okay, well, talk to the pharmacist when you talk to them now. Or make sure that you talk to your doctor about the fact that you say you've lost 20 pounds without meaning to. That basically circling back to the providers themselves and keeping them in the loop seemed to be a common thing that could be very important for these patients. Another question, are you aware of any commercial pharmacy chains that might be inclined to introduce this type of program? I personally am not. We haven't really gone to build those relationships. COVID has made things a little bit difficult in some regards, but that is something interesting. I could probably foresee more independents picking it up before I could see chains. But I also know that there are some chains who are really taking steps towards more holistic healthcare, other services. I think Kroger does or used to have a specific pharmacy, like nutrition-related pharmacy residents, I want to say, or pharmacy rotations that focus on nutrition. So I could definitely see, we haven't gotten to a point personally with the charitable pharmacy to start talking to chains, but I think I could definitely see some of the ones that have a more overall health-oriented program picking it up at some point.
Thank you. I think that is probably our last question for Beth, unfortunately, because we do have, excuse me, other presenters. So with that, I would like you to welcome Sarah Baylog, who is a thoughtful and strategic government relations and patient advocacy practitioner with almost 2 decades of experience, including 6 years as a legislative aide on Capitol Hill, 2 years as a congressional district director, and over a decade as a health policy expert and lobbyist at the state level. She has served a variety of patient advocacy organizations in regional management roles for both government affairs and advocacy, including the American Heart Association, the March of Dimes, and the Leukemia and Lymphoma Society. So Sarah, take it.
Great. Excuse me. Thanks, Meredith. Hi, I am Sarah Baylog, and I am the coalition coordinator for the Florida Malnutrition Awareness and Education Network. So we are a statewide group that's comprised of folks providing direct access to food in the field, to registered dietitians, to hospital staff, to we have several government agency coalition members. So we're really a broad and deep coalition that focuses on raising awareness about the needs of specifically Florida's senior population, because no surprise, Florida is tied of all 50 states with Maine for having the highest proportion of seniors, and has the second highest overall number of seniors behind California. So we're talking about 5 million seniors in the state of Florida. Okay, so next slide. So what our coalition has really been focused on in the last year or so has been some of the work that is coming out of the state government. So this year in 2021, in October, the state officially approved and finalized their state plan on aging through 2025. And so we are going to be working to try to leverage that, the kind of the excitement about surrounding that new plan, and work at the hyper-local level to try to direct some of the attention and focus to senior malnutrition. And then also, I had a very great opportunity to serve as a member of the Department of Agriculture's, the Florida Department of Agriculture's Food Security Advisory Committee. And we worked throughout 2021 to put together a series of policy recommendations and issue statements about several different areas within hunger and malnutrition and food access policy, and just presented those to the state actually yesterday. So next slide, please. So Florida is, every state is different, right? I mean, if you've worked with one state government, you've worked with one state government, as the saying goes. Florida's splits their administration of a lot of the programmatic support for seniors between the Department of Elder Affairs and the Department of Agriculture, and our coalition works closely with both of them. And we have seen that there has been, not surprisingly, some kind of, it can get clunky when the USDA is working with both agencies. State funding is flowing to both agencies. So we really see our coalition having a really strong charge to always be the squeaky wheel and making sure that malnutrition issues and that seniors' needs are always front and center as these agencies are carrying out their day-to-day business. Next slide. So with the newly approved plan, Florida, is an interesting state because it's just population-wise, it's very large. B, physically, it's very large. And, C, there are so many metro areas. There are so many different, just hospital systems and places where there are pockets where there are huge lack of access to care, and it's really very spread out far and wide. It's a very diverse state. It can be really, really challenging to come up with one message or or one set of recommendations in a state like Florida. So we are going to be working this year to really try to build out relationships with the executive directors and the boards of these 11 regional agencies on aging to try to ensure that, because unfortunately the state plan didn't really have the specific focus on senior malnutrition that, you know, we as a national coalition would have liked to have seen in that plan. We're just taking that as a charge to build out relationships in each of these 11 areas and try to help educate those members about the seniors that are at risk for malnutrition in their communities. Next slide. So beyond the state plan on aging, the other opportunity that we've had this year, as I said, is this really, this great process. I don't want to call it a report because yes, it's a report, but it's really been a year-long conversation at multiple levels that's really drawn on a diverse set of perspectives and has come together to make both assess kind of the state of where we are on these topics that you see here, as well as ways that we can improve Florida's performance and the state of Florida, you know, the health of Floridians in each of these areas. So I was able in my position as coalition coordinator to really help shape the senior malnutrition and hunger section of the report. So next slide. We really, and I want to just say thanks to the Defeat Malnutrition Coalition, to Meredith, to everyone who really provides folks like us at the state level just such really good, robust, data-driven materials and a framework to help inform and educate our coalition partners and our government partners. So we were really in a turnkey way able to say, here's what, you know, the experts in this issue say are the most critical things to improve patients' lives. And in Florida, it became really, really clear really quickly that we have an absolute dearth of adequate surveillance. We have very little data collection at the state level, and we really, really need to focus where the state has any ability to invest and require data collection. We really strongly encourage them to do that. And then also we just felt like there needed, you know, to be better coordination and in a more culturally competent way, because Florida is so diverse and has so many, you know, populations at risk, that one of the things that we really need to see Florida improve on is making sure that we're meeting seniors where they're at, essentially. And much like with what Beth presented, and I love the question about, you know, was there any hesitancy on the part of the folks that Beth was working with in the screening process? We talked a lot about that in our discussions with the Food Security Advisory Committee, is that, you know, there are certain, you know, people who view food stamps in a very negative way, regardless of kind of either the richness of the benefit or the process. They're just kind of fundamentally not interested in pursuing that as an option when it is so clearly a solution for some of the malnutrition and hunger problems that they may be experiencing. And so that was just another area that was really identified that we need to, as a community and as a coalition, come together and make sure that we are, you know, as Beth said, just echoing, building trust with communities and with individuals, making conversations comfortable, making sure that there's support for finding access, you know, not just handing off and making a referral, but doing our best to try to follow up and ensure that they were able to apply, you know, just kind of the continuum of support in making sure that we are helping seniors use what's available now, and then also going the extra mile to try to push the state forward to improve access and, you know, adequate nutrition overall. Next slide, please. So this, and I'm happy to send out a link to the whole report. Of course, I think it's fascinating. This is just the second part of the senior hunger and malnutrition section. The senior hunger is separate, and just as Beth alluded to, we really did try to tease apart those two things and make sure that it's clear that you can not be suffering from lack of access to food or food insecurity, but also at the same time be experiencing malnutrition and vice versa. So it was just really important. And again, I think that speaks to the need for adequate data collection, that it's really, especially when you're talking about a state like Florida that has, such a high population of seniors, that is already, hospitals are already desperate to track and prevent readmissions. And when, we see some of the most common procedures that lead to readmission being, conducted in the senior population, and just really trying to help bring, hospital systems, hospital RDs, primary care physicians, really just that, again, the continuum of care of making sure that everyone is aware of malnutrition as a risk factor for readmission. That's just kind of part of the overall part of the conversation about data collection. So we feel like we're on the cusp of kind of untangling that knot in Florida and finding a way to connect all the dots between providers, folks who are suffering a lack of access to food. We've got a really robust multiple markets with really, really great Meals on Wheels organizations who are partnering with us on this. So we're trying to be creative and think outside the box, essentially. Next slide. So our coalition focus for 2022, coming out of kind of the more nuts and bolts wonky side of both the state plan on aging and this policy recommendations, we as a coalition are really working to try to crunch the numbers and bring this issue to lawmakers' attention and say, here's your population that these are your constituents and they're at risk for malnutrition, and here's what that means. Here's what that means for healthcare spending in your district. Here's what that means for overall health and morbidity and mortality. So we took just demographic numbers and looked at the communities where statistically seniors are going to be the most at risk. And we are taking a lot of the great materials that Meredith is going to be talking about in just a second, and bringing that education and awareness about malnutrition as a risk factor to the very lawmakers who represent the people who are most at risk. Next slide. All right, that's it.
Thank you so much, Sarah. Do folks have questions? I'm going to give people a few more seconds to type in just in case. But Sarah, you covered so much material and covered it so thoroughly that folks are stunned into silence. All right. If there are questions about Sarah's presentation, we can take those at the end. I'm going to go ahead and show you what Sarah was talking about. We released state toolkits for advocacy in May of last year. However, we wanted to highlight those again because, the material is still very timely, and also as state legislative sessions are in progress, this would be a great time for folks to reach out to your state legislators. So this is the link where the toolkits are, and I'll have that up again at the end. So we have two separate toolkits, one for state legislators in particular. So this is a document that you can actually give to a state legislator. There's also, by the way, an infographic on our website that distills this 45-page toolkit into one page. so that, folks who are pressed for time can get the very, very top line items, because, sometimes it's unrealistic to expect, a legislator to read 45 pages. However, their staff are usually more willing to do that. So as a side note, as you can see, we have a lot of content in this toolkit. The appendices are not to be missed because they're very full of sample legislation, press releases, sample op-eds, social media, graphics, etc. So don't skip over the appendices when you're looking at the toolkit. It comes with a top line summary, so that way, this is also kind of a one-pager for legislators. Some of the topics it covers include that malnutrition is a public health issue, how expensive it is, policy actions that have already been taken on older adult malnutrition, and state best practices. Connecticut and Florida are highlighted here, but there are also a ton of other states that have made it into the toolkit. So encourage you to check those out. We also, as I said, have a second toolkit. This one is specifically for state advocates. So this is for you. This is for folks who might want to advocate on behalf of these issues, but don't necessarily know where to get started. Also comes with a handy top line summary. Why advocacy is important and what it is exactly. How exactly to communicate with your state legislator, because it's really, it's easier said than done that, oh yes, just reach out to your state legislator. Well, how do I go about doing that? This can tell you. We have sample scripts that's very helpful, especially if you're inexperienced, or frankly, if you're shy or an introvert. Sometimes it helps to have it written out in front of you. So, that we found that is useful. We talk about the pandemic and social determinants of health. And those are the highlights of those toolkits. Again, they're both over 40 pages long, so highly recommend checking them out yourself. The toolkits are highlighted here on this slide. And again, the recording, the slides, all this material will be posted on our website in the next day or two. So, and we can send you all a link when it's posted. I'm going to put it in the news and updates section so that, it's all on its own page, and it should be easy to find. So I see there are some questions that have come in for Sarah. And if you have any questions for me, feel free to put those in the chat or Q&A as well. So Sarah, what would it take to fill the data / surveillance gap in Florida?
Frankly, it would take a greater investment from the state, just in terms of state funding. That's part of why we've really zeroed in on trying to build out a legislative champion for this issue. Florida's not alone in being a state that is hesitant to spend state dollars. I think Florida is unique right now in kind of a real insistence that government spending be as minimal as possible, and that really presents a challenge when, frankly, you're just talking about the volume of seniors that we have in Florida. So, I mean, the shortest line from A to B would be increased state funding. Short of that, of course, any federal support, that can trickle down through any of the agencies that are already working on this issue. But definitely our call to action to the state is to find a champion and a voice for seniors and say, we need to, as a state, spend our dollars and invest in data collection.
This question also is for Sarah, and it's along the same lines, but slightly different. How do you think we can improve the Florida Department of Elder Affairs annual assessment questions and data that's collected on all Older Americans Act clients about nutrition status? And I can talk about what's happening at the national level with that, but what
Meredith,
Florida?
Yeah, that's exactly, making Florida do it would be great. So, I think, but I do think also there is a kind of a unique Florida disconnect, because we do have two agencies that are at sometimes kind of in overlapping roles. It's not, and it can get even more complicated because the Department of Agriculture commissioner role is a statewide elected office. The Secretary for Elder Affairs is a governor appointee. So you've got some kind of turf issues there. So it can get real complicated real quick. But I mean, Meredith, yeah, if you can speak to the shortest line from A to B is for the federal government to say, do this.
So in exciting news, the federal government is working on this. ACL, the Administration for Community Living, which is the HHS agency that oversees the Older Americans Act programs. It sounds like this questioner knows, but for those who don't, the Older Americans Act nutrition programs and other programs in the Act, home-based services, et cetera, every participant undergoes a survey that is administered. And there is currently, after some agitation by our coalition and others, there is a technical expert panel that has been appointed to add questions on malnutrition and food insecurity to the annual assessment questions. So Bob Blancato, our national coordinator, he has been appointed to this panel, and so have about a dozen other very qualified folks, some of whom are also members of the coalition. And so they will be coming up with questions to capture the incidence of nutrition risk and malnutrition and food insecurity, to try to figure that out and its prevalence among clients, and just all of that, to try to capture that data. And we're hoping those questions will debut in hopefully in surveys this fall, but I'm not entirely sure when they will be approved. I know the panel is going to be working through April, and then it's going to have to, go out for comment, et cetera. But hopefully by the end of the year at latest, or early next year, who knows, there will be improved questions on the survey. And those questions will have to be answered by all the, all the surveyed folks. So that is, so that's an example. There's federal work underway on this. There's also a question: is there any push to get increased federal data that can be stratified by county for senior food insecurity? We've been in conversations with USDA, the Department of Agriculture, about getting that together. There's some there's informal survey stuff done by other entities. I believe Feeding America has some on food insecurity in the senior population. I know that United Health Group does surveying on older adults' health status, and that includes nutrition risk. But yeah, we are trying to get a more coordinated federal effort going. And there's actually another question for Sarah. how could you minimize or prevent overlapping the two agencies, so agriculture and elder affairs? Is that possible?
With 3 minutes left, not really.
Sorry.
We just have to, again, I mean, that again, we have to find a legislative champion, because the lawmakers hold the purse strings and they have the ability to tell the agencies what to do. So that's really our goal, is, again, using these great toolkits, just go straight to Tallahassee and build a champion for seniors at the Capitol.
Well, I think that's actually an excellent note to end on. We should all be building champions within our state capitals in order to get movement going across the country on all of this. So that is ultimately the entire point of this webinar. So that was a great summary. Beth, Sarah, anything else before we close out?
Nope. It's been great to be with you all.
Yeah, I would say the same. Thank you so much for having me. I appreciate it.
Of course. And so all of these resources from the chat, everything, we're posting it, and you'll have the link. It'll be there. So with that, thank you so much. This has been an excellent webinar, and I very much appreciate your time and effort today. And thank you all for attending.